Hey everyone, welcome to another episode of Darshan Talks. Today's podcast is going to be about patient assistance programs. We're going to talk a little bit about what do they mean, what are the limitations. There was a recent court case on the topic, so we're going to talk to our guest today about it. So if you are in medical affairs, if you are a healthcare provider who works with patients who might need this, if you're a patient, what are the implications of this recent court case? What are patient assistance programs? Do patients like them? Why don't they? Why do they? Et cetera, et cetera, et cetera. Those are today's conversations. Our guest today is someone we've had on a few different times before, but for those people who don't know him, he is the National Managed Care Practice Leader and Peer Solutions Center of Excellence Director at Willis Towers Watson, now known as WTW. He's been a guest with us multiple times. The very famous, the indomitable Kenneth White. Hey, Ken, how are you? How you doing?
I'm doing great. Indomitable. I like that. That's pretty
I
cool.
was hoping that I actually used the word right as I said it. I was like, I think I know what that means. But
The use of incredible, meaning not credible.
decredible. There we go.
Decredible.
I do have to emphasize both of us are attorneys, but this is not legal advice. I'm a pharmacist. It's not clinical advice either. This is just for discussion purposes only. These are considerations. They do not necessarily reflect the opinions of the guest, the host, or our employers or clients. If you like what you hear, please leave a comment, please subscribe, please share. Please feel free to ask our guests questions. You can always find me on Twitter at Darshan Talks or go to my website at darshantalks.com. On the other hand, you can actually reach Kenny on LinkedIn, and I'm showing his LinkedIn profile right there. You can also find him by email at kenneth.white@willistowerswatson.com. They obviously haven't updated their website or their URL yet. Are they going to?
I think the holdup is that WTW seems to be like Weight Watchers.
Is that right?
Technically, I think it is. I'm not really sure, but I think
Has
that's
someone
the
been thinking
holdup.
this?
So, I mean, we can't shorten it to WTW.com unless and until we get over that hurdle. And if that's true, then maybe Oprah isn't selling it to us. I'm not sure, but I would really like it if they could do that, because Kenneth.White at WillisTowersWatson.com is a lot to type all the time.
But it could just be wearewtw.com.
Hey, look,
I'm not in charge of
I'm the
branding.
National Managed Care Practice Leader. I'm not the CEO.
Fair enough. And lastly, you can actually find out more about the event that Kenny is going to be a huge part of. Kenny, you want to tell us a little bit about this event?
Sure. Every year we have two events. One is the Provider Forum, which, as the name sounds, is provider centric, and the National Managed Care Roundtable, which is payor centric. And we've been doing these for 20 years. They're being done concurrently this year in Nashville in July the 20th and 21st. Different tracks. One track for managed care, payor, admin support folks, and one track for hospitals, health systems, and physicians. And again, that's live in Nashville. You can go to that website. It's primarily for people in risk transfer, quantification, mitigation, finance, legal, etc., with regard to risk associated with healthcare. And we have a fabulous panel on pharma risk that Darshan will be a panelist on. So looking forward to that.
I'm very, very excited to be there. I'm going to be talking to people who are going to know so much more than I do. So I'm excited for that. And
that's how we all learn.
What's that?
That's how we all learn.
That is
why
exactly
I talk to you. You know more than me.
Well, I'm really excited because I get to talk to people who are super smart, and I think that's always a good thing. I'm talking to one right now. So thank you. So now that we have the pleasantries out of the way, let's talk a little bit about what I'm excited about, which is let's start with the basics, which is what exactly are patient assistance programs and why do they matter?
Okay, PAP, or patient, because we love acronyms, which Patient Assistance Program, PAP, which is not to be concerned with PDP, which is Part D plan, which they are connected to, believe it or not.
Or the pap smear. But
or the
yeah.
pap smear are which is not connected in any way. But in this instance, they are programs that are either run by manufacturers, operated possibly by PBMs, large ones, or charities. And I use charity with air quotes because some of these charities are set up by the manufacturers as a way of sidestepping some of the other rules with regard to them, that provide assistance to patients to cover some or all of the cost of a given medication. There are multiple ways of doing that. Um, One is through the one that comes to mind easiest because they advertise all the time is Goodrx. So those or other um, pharmacy cards that you can sign up for one way or another. You may get a card. It may be just something that you can access via online or at the retail pharmacy. Will give you a discounted price on a given medication. That could be a small discount. It could be a large discount, but that is completely outside of insurance. So whether or not it's government insurance, Affordable Care Act, CMS, Medicare, Medicaid, or commercial carriers, or employer ERISA plans, those are completely outside. The plans aren't billed for the drugs. It is a completely um, secondary system whereby those entities have negotiated separate prices for certain drugs directly with manufacturers. They offer those discounts to the people. They there are benefits to them. They are paid via the manufacturer most of the time. There are rebates involved, and in that situation, it is a discounted drug program for people who are insured but want to go outside of their insurance or uninsured. And then you have the formal PAPs, which are for the most part manufacturer driven. Um, Lilly Cares Foundation, um, Pfizer has one, Novartis has one, um, GSK has one. Most of the large manufacturers have them. They may be set up individually by drug, or they may be an across the board for various drugs. They can be direct from the manufacturer. They can be secondarily set up through a foundation or charity. And those are in part using insurance and are directed at the copay amounts that any member would have to pay. So if you look at any medication, you can go and get a generic medication and pay zero for it. The Tonstoffel principle, as I learned in economics, which is there ain't no such thing as the free lunch, means it's not free. Somebody's paying for it, but you didn't have to pay anything directly at the retail drive-up pharmacy window to get it. Or you may have to pay what's called a copay or coinsurance. So the drug costs $10, your insurance paid 8, you have to pay 2. That drug may actually have a list price of $1 million, and the contracted amount is 10, and they pay 8, and you pay 2. Which is where we come into the whole coinsurance copay parts. Some of these medications obviously have extraordinarily high costs, um, $200,000, $300,000, $400,000 a year. And particularly for those on Medicare or Medicaid, if you do not meet the criteria for catastrophic drug coverage, then you're paying an extraordinarily hefty price. If you are involved in an ERISA plan for your employer and you have a high deductible health plan, then you're paying a very hefty price because these medications are usually tier 4 drugs, which means they are the most expensive on your plan. And in that case, the drug manufacturer may offer a payment assistance plan so that your out-of-pocket expenses are significantly reduced. There was you mentioned a case that came up very recently, last month actually. There was one back in September of last year that was a Pfizer case where Pfizer had actually gone to the OIG for the Department of Health and Human Services, asking them for an advisory opinion as to whether or not their PAP violated the anti-kickback statute. And they had a charity, and the OIG said, well, that's under a separate review, and we're not issuing an opinion with regard to that. And then the second one was the direct to the patient payment plan. And in that situation, the OIG said, we, which really was weird. They said that we don't find that it violates there's actually a statute that's called the Beneficiary Inducement Statute, BIS, the benefit, and they said it didn't violate that, but it might violate the anti-kickback statute because it induces people to buy the drug. Going, well, why doesn't that fall under the Beneficiary Inducement Statute? But hey, Pfizer didn't like the ruling, so they went to the district court, as is the jurisdictional stair steps for those things, and asked the district court to say they were okay. And the district court said, no, you're not okay, because quite frankly, your whole plan is nothing more than an inducement for people to buy the drug, because if it's too expensive, they can't buy it. And, Pfizer's response to that was, well, we don't have any nefarious intent. It's not corrupt. And the district court said, the anti-kickback statute doesn't require corrupt intent. It simply requires that you're doing something that will induce someone else to buy a drug that they would not have otherwise bought. Because it's healthcare. You can go buy a car and they can, cut the price and cut the price and cut the price in order to induce you to do that, to buy the car, but flip it to a drug and it violates the anti-kickback statute. So that was, back in September. So these things have been under the microscope for a while. The payer industry has been significantly involved in lobbying, not against the programs, because it's hard to argue that if the drug manufacturers want to charge $1 million for a drug and then give you, a huge discount on it, that it's a problem. The insurance companies, the health plans were like going, we have formulary tiers for a reason, and that's to manage the cost of the plan. And if everybody got the best of the best, whether it was necessary or medically necessary, or there were no other alternatives available, then no one would be able to afford the insurance. So, we have to be able to manage that. And if you're going to induce people by covering their copay costs, which are there for a reason, then it blows the whole actuarial support for the premiums and the cost, of the plan out of the water. So they had these things called, and this is what I think we originally started talking about, was the accumulator or maximizer programs that the health plans and the standalone PBMs started developing, which was to allow people to use the PAPs all they wanted to. You just weren't going to get the benefit of the PAP amount towards your deductible. So if you go to Rite Aid, or, Dwayne Reed doesn't exist anymore, right? It's all Walgreens, and or CVS, wherever, and you present your prescription and the drug cost $1,000 and your insurance company pays 70% of that, and so you owe $300. Well, $300 is a lot of money to some people, and if you have to have that drug twice a month or once a month for a year, that's $3,600, not $300. And if you have a high deductible health plan with a $5,000 deductible, then you'd get $3,600 versus of out-of-pocket expense paid by you towards your deductible. But if you're not actually paying that, because the PAP steps in and pays a lot of that for you, then two things are true. One, it blows the actuarial underpinning for the pricing on the health plan premiums to start with out of the water. And two, it eliminates the health plan's ability to help manage the cost of the plan for everybody, including ERISA plans. So we have employers involved here, because people aren't being impacted by the behavior modification intended by the formularies and the copays. So that's where the problem. There's the rub. It's money, but it's money with a reason.
So you gave me sort of what I would describe as the lay of the land. What I want to start off with is by sort of exploring bit by bit to simplify it for someone as simple as I am. So
I'll have to make it much more complicated if we're going to do it that way.
let's start with the basics. So is there a difference between a copay assistance plan, Goodrx, and a patient assistance plan? Describe those three words and how they connect to each other.
From a PhRMA perspective, not really. They work all the same way.
Okay. From a patient perspective.
From a patient perspective and a payor perspective, they're different because of who's paying.
Okay.
On a Goodrx thing, completely outside of insurance, even if you have insurance, even if you have great insurance, the Goodrx price on a given drug that you may be needing, may actually be cheaper than what it costs you under insurance. So, and there's no financial eligibility for those. A lot of times the eligibility is simply signing up, where PAP programs are supposed to have eligibility requirements. So in that situation, it's just a drug discount program. And it may be a great drug discount program, but it doesn't impact your insurance at all because the claim isn't reported your insurance. Your insurance pays nothing towards it, nothing. It's just, the drug was $30 or $100. If you use Goodrx, the drug's only $40, and so you give the pharmacist $40 and walk out with the drug, and that's it.
Right.
If you on a PAP,
before you continue, so what I hear you saying is it is a straight discount plan because of a negotiation that, in this example, Goodrx already had with a bunch of different manufacturers. Is that correct?
Correct. And there are a number of them. We're just using Goodrx because I see their commercial all the time. But I mean, there are a number of those programs. Some of them are free. Some of them you pay for. But it's basically the exact same thing. It's just a drug discount program.
Could you give a couple more examples in case people are interested of other companies like Goodrx?
Oh, wow. I don't know where CVS still has theirs, but they used to have one.
CVS used to have one. Okay.
My guess is Walgreens has one.
So most pharmacies, you're saying, may have their own version of this.
Yeah, and if you just go online and put in, drug discount cards, Google will pop up a whole bunch of them.
Got it. And is there a way to tell which one is good and which one's not up front?
As far as you tell most of everything else, you'd have to read the fine print as to what it is. Obviously, some of them you pay for. It's AARP kind of a thing. You pay and get, access to. And some of them are free.
Okay, so that's just a different beast altogether. It's completely
right. And they don't cover all drugs, by the way. I mean, they're not going to cover your, the $300,000 drug stuff. I mean, they're, we're talking much more mainline drugs, for which they're probably isn't a generic, because if there was a generic, it wouldn't make any sense to have one.
Right.
I mean, it wouldn't make any sense to have a drug discount program when the drug is only $3 anyway. I mean,
Absolutely.
you know,
And are these, so what I hear you saying is it may be with, in general, these are typically, for, as you put it, mainline brand name drugs. You're probably not going to see something with a generic. You're probably not going to see something for a super expensive drug. It's usually those middle of the road drugs where
yeah,
you're going to see these.
right.
I say middle of the
I
road.
know the biosimilars probably wouldn't be in there either, because, you know, I, in that world, they can be relatively inexpensive, or they can be, I mean, it's sort of, biosimilars tend to be like, fake Rolex watches on Times Square. I mean, uh, if they want to sell them for $30, no one cares. If they want to sell them for $3,000 when the real Rolex was six, then they care,
Right.
because everybody expects the $30 Rolex to be fake. People wouldn't necessarily expect a $3,000 Rolex to be fake, even though it probably is, because I'm not sure that there are any $3,000 Rolexes. I don't own one, so I don't know.
Fair enough. So we've now gotten out of the Goodrx world, which takes us now to the copay assistance programs. Are copay
Right.
assistance programs the same thing as patient assistance programs?
Yes. For practical purposes in the pharma world, you are correct.
Okay, good to know.
Let's not
Okay.
worry about we're staying pharma benefit, not medical benefit.
Correct.
That would be another conversation completely.
Fair enough.
So
Let's just stay in the
pharma
pharma.
benefit, those are basically the same.
Okay. So all we're doing in many cases is adjusting the cost of the copay that an individual has to pull out of their pocket.
Correct.
And that is what, so patients would love this for the most part.
Oh, sure.
Okay.
So
But it obviously,
there's two of those too. So let's define it so that we know exactly what we're talking about.
okay.
There, for CMS,
Mhm.
and I don't know why CMS isn't CMMS, but it's just CMS, the Center for
Right.
Medicaid and Medicare Services. Um, you know, the for Part D under Medicare, and for the best price part of Medicaid, the rebate requirements for Medicaid, um, there are programs that are outside of Part D.
Right.
So you can have the same sort of program run by a drug manufacturer directly between the manufacturer and the patient, although it's probably routed through a retail pharmacy for purposes of delivery. Um, that is outside, that does not get reported to your Part B. So
Repeat that
it
whole thing for me. I totally lost you.
it operates sort of as like a Goodrx. I mean, it doesn't count towards Part D. I mean,
Okay.
and then there are versions of that are in the commercial world that do count, which is where we got the issue with the most recent lawsuit that came about, because the health plans were enacting uh, basically computer programs that were eliminating the ability of Darshan to use what he didn't pay
Right.
towards his deductible.
Right.
So if you were going to have to pay $1,000 for a drug as a copay, and the manufacturer through a PAP steps in and pays all or most of that $1,000 for you, the insurance or health plan didn't want to give you credit for the deductible amounts that you were paying for the $1,000, because you didn't pay it.
Right.
It got paid for by somebody else.
Right.
In regular insurance, there's a rule, um, and it's called other insurance,
Hmm.
where if you have a deductible or a self-insurance retention for a program of $1 million and you don't pay the $1 million, but somebody else steps in, pays it for you, unless you have the right insurance terms and conditions in your policy, it doesn't count. You have to pay the $1 million because we've set up this whole thing and done our pricing based upon you paying the $1 million. Same thing with health plans. You have a $6,000 high deductible health plan. We made the pricing based upon you paying the $6,000. Now, we don't care if you're a student that your parent pays the $6,000 or if someone else pays the $6,000. What we don't want to have happen is two things: hospitals, physicians, DME providers, and pharma manufacturers paying the $6,000
Why?
because that's an inducement to use their services, and their services, when they do that, are usually more expensive than other people's services.
So, because it would be under Medicare Part B or D, depending on what type of drug it is. That's the
Or
inducement you're referring to.
correct. D being outpatient drugs, for lack of a better phrase, and B being inpatient.
And that's why you said hospitals. I was trying to connect all of those components as well.
Yeah. So I mean, in that situation, I mean, for instance, in Florida, I know that because I live in Florida. You know, if you were a physician, if you were not farm doctor but MD doctor, and you waived copays for your patients to come see you, I'm not going to collect the $20. I'm just going to charge the insurance and get what the insurance pays me back. That's actually statutory fraud in the state of Florida.
Right.
And it's fraud because you're messing with the actuarial underpinning of the entire program.
I hear you, and I understand the reason why it exists. But I can tell you from a patient's perspective, I'm going, it's a lot of money. And like you said, it's not a one-time cost. It can be an accumulating cost. So while I recognize your perspective, I guess my question to you is, as a patient, and I had to do this with Ozempic recently, where my out-of-pocket was something like $400 per time I used the drug. Sorry, as opposed to something else. My question for you is, yes, I understand that from a regular, and I'm not trying to make it personal because that's never helpful to the conversation. What I'm trying to understand
But it's
is,
always personal because we're all patients.
yes, but what I'm trying
We're
to
all patients.
understand,
And from a patient perspective, from my own wallet perspective, would
yeah,
I prefer to be able to do that? Yes, absolutely. But here's the backside of that.
right,
If we let all that happen, and anybody, and let's face it, of the hundreds of millions of people that are covered either through commercial or government health plans in this country,
yeah,
the vast majority of them, vast majority of them, do not need $200,000 or $300,000 drugs.
right,
They don't need $100,000 drugs.
right,
Now, does that mean that most people can afford $400 a pop if they need to go get a prescription filled once a month or twice a month? No, it doesn't.
right,
But everybody's health coverage is based upon the law of big numbers. It's the insurance underworld. It's the actuarial underpinnings of it all. We go through and figure out how much it's going to cost on an actuarial basis, and we charge for that. The federal government pays Medicare Advantage programs a per member per month fee
right,
for everybody that's signed up for that. That includes the costs of all of the Part A expenses, all the Part B expenses. If it's a Part D plan, all of the Part D expenses, all of the dual expenses, which includes hospice and skilled nursing facilities and things like that, which normally wouldn't be covered under traditional Medicare. So it, it includes all of that,
right.
and it's based upon what the average amount people spend and what the administrative cost of that is. And then if you start moving the variables from an external perspective, then you mess with the methodology that created that, and you throw it all out of kilter.
So I don't know why, but I seem to YouTube seems to believe that I really like A Beautiful Mind, so it keeps popping up on my screen. But it reminds me of game theory, which is, in some senses, the idea is that what's good for the group isn't necessarily good for the individual.
Of
And
course
at a
not.
certain point, people start going, I need to look out for myself, forget the group. And game theory considers that aspect of it. To me, what I hear you talking about is really game theory. I don't
Yeah.
know if people, I mean, I forget
If
the
I benefit you,
right.
so when the Affordable Care Act came out, it's the worst piece of legislation that was ever done. Not because it's a horrible idea. It was just a horrible piece of legislation. It,
My
you
ex
know,
boss did it, so I feel a little. But anyway,
it's
moving on.
just, they they made something that could have been supremely simple, and accomplished the same goals, and made it extraordinarily complicated.
Okay,
Um, in part because of all of these variables that move the needle one way or another. So in that situation, they came out and said, "Oh, we're gonna, we want you to do this because everybody's going to save $2,000." Well, they did it. Nobody saved $2,000. Everybody actually ended up paying $2,000, not saving $2,000. Why? Because they gave all of these government subsidies for people who otherwise couldn't afford health insurance to get health insurance. So is that a bad idea, that people be covered for catastrophic or normal? No, it's not a bad idea. But nothing is free. There ain't no such thing as a free lunch. Somebody pays. And in this case, it's the taxpayer. So if you're an employer and you have an employer-based plan, and the cost of that employer-based plan is spread between you and your employer and all of the rest of the employees of that employer, even whether there's 50 of them or 50,000 or 500,000. I mean, you've spread the cost. Well, when the cost starts going up and up and up for certain people, and then everybody has to chip in some to cover that. So while Darshan gets a good break on his drug costs, I now have to pay part of Darshan's drug costs, which I was paying already,
right.
because that's just the way the system works. But if you throw the system out, now I got to pay more, rather, because you're not, and I use this with a huge grain of salt, you're not paying your fair share. You know,
And that's a fair
I'm
question.
sorry,
That's a fair point.
I'm not the person who's sick. I'm not the person who needs this. I'm not the person who went to Corinthian college and got defrauded. So why are you using my $20 billion to suddenly pay off everybody else's student loan debt? Because it's not cancellation.
Right.
Someone's paying for it. In this case, the
Right.
taxpayer. In the other cases, if it's CMS, the taxpayer is paying for it. If
And
it's
that's why
otherwise, it's the employer and the employees that are paying for it.
and that's the reason I wanted to ask this question because
But I mean, it's a great idea for those who get the benefit.
right. But in this specific instance, in the latest lawsuit, and I have messaged it out on YouTube for those people who go to it. But for those people who are interested, in this case, the government was the one who sued, and as you pointed out, that's why they sued. That's why they had standing, because the government representing the taxpayer was footing the bill. Is that fair?
Yeah, actually, it was the pharmaceutical research manufacturers that sued, and they sued the government.
I'm sorry, the other way around.
Yes. So in this
The
case,
government defendant, yeah,
what happened is that the pharma industry lobbying group,
right.
there
Pharma,
are several
right.
of them, but one is the Pharmaceutical Research and Manufacturers of America, I believe is the name of it.
I believe that's right. Yeah,
Um,
PhRMA.
so in that situation, they wanted step back one step further. The PAP programs came into existence. The response of the health plans was the maximizer programs or the accumulator programs, which were designed to eliminate the ability of the patient to count their benefit that they were getting from the PAP towards their deductible.
Right.
Okay. The pharma industry said, well, wait, that's not, we're trying to help the patients.
Right.
And I'll skip over all of the feigned altruism of that, and go straight to the point. It was, as you mentioned just a second ago, helping the patients. I mean, you could help them better by charging less for your drugs, probably, but be that as it may, if the drug cost $100,000 and your copay amount was more than you could afford, then their PAP program steps in. And everybody's seen this. Every single time you have looked at one of those drug um, advertisements on TV, of which there are thousands now, at the
Mhm.
very end, if you can't afford your drug, maybe Altera can help you. That's the PAP. That maybe
Ah,
Altera can help you. That's the PAP. So in those situations, they wanted to jump in and say, look, we're helping the patients. We're the good guys here. Don't let the health plans hurt the patient
great.
because you always have to turn it back to the patient, because then you don't get any sympathy. So, we want you to help the patient out by preventing the bad evil health plan from refusing to count the amount of money that we're paying. And in that situation, CMS came out with a rule that said that the drug manufacturers had to come up with a way of ensuring that the amounts that they were paying through the PAP program were going to the patients. And of course they weren't if the health plans were refusing to count that towards their deductibles or their copay requirements, then it wasn't going directly to them. So they wanted the pharma industry to come up with ways in order to make that happen. The pharma industry came back and said, look, guys, we can't do that. Logistically, we don't have the ability to do that. Our hands are tied. And of course, CMS came up with some lovely ideas, which were both unworkable and horribly expensive and administratively a nightmare, which I
Right.
don't blame the pharma industry for going like, no, this is not really something we want to do, because that really just didn't make a whole lot of sense. So the pharma industry sued Health and Human Services to overturn the final rule.
Right.
And the court came back and said that Health and Human Services didn't have the authority because they were misinterpreting the best price part of the statute, because patients aren't purchasers under the statute for best price purposes for Medicare and Medicaid. And I know that that's horribly complicated, and it is horribly complicated, but the amount that the patient actually pays or does not pay doesn't go into the calculation of best price for the required rebates under Medicare and Medicaid. So the court said you CMS, HCMS, HHS, you can't have a rule that makes them account for that, because it's not part of the statute. So we're back to square one. The only thing that it really did was prevent the pharma industry from having to pull their hair out over something that wasn't going to have any impact anyway. The real question here is, because this really does help the patient, and in most cases, the help to the patient is probably greater than the overall harm to the health plan. Even if you aggregate them all up,
Sure.
you know, it's hard to say that you should be, doing that. But from a technical, actuarial, pricing perspective, it makes perfect sense that the health plans wouldn't want to include the amount of money that the drug manufacturer is giving, because in my opinion, it's all violative of the anti-kickback statute or the Beneficiary Inducement Act, because the real reason why I'm going to make this drug affordable for you is so that you'll use it over some other drug, which is less expensive, probably. Now, in certain cases where there's only one, then I guess it's,
But
it doesn't match. But
I'm going to raise another point on where we are well beyond what our time should be. But I'm that the assertion that that's the reason why a doctor would choose one drug over the other, which is the copay assistance plan or the patient assistance plan, seems disingenuous, because the truth is that a doctor in general, I would imagine, is choosing a drug that is right for the patient because it's right for the patient, not because it's cheaper or more expensive. My experience talking to doctors, for the most part, they don't know what a drug costs. They just want to give the drug that they think is right. Now, I will admit,
they also, for the most part, don't know hardly anything about pharmacology.
I would disagree with that statement. They don't know as much, and they start as much.
How many years did you go to pharmacy school to learn
6 years.
all about pharmacy and pharmacokinetics and pharmacology?
Sure.
6 years, right?
Yeah.
The average doctor gets 2 classes.
Yes. However, I also got 2 classes of pharmacology. However, what they do get a lot of classes on are things like physiology and how pharmacology impacts physiology, which is pharmacotherapeutics, really. But that is, go ahead.
In answering your question, it sort of begs the other question. Do doctors, and I'm certain some of them do. I mean, this is not an indictment of the entire medical industry. I just think that most cases, doctors don't have a great grasp, which is why we have so many medications that are ordered that have contraindications to other medications that the patient is already on. Either the doctor didn't know there was a contraindication, or 2, they didn't know the patient was on the other medication, which was equally not very good.
There's a third answer, actually.
What's the third one?
It doesn't matter is actually a third answer, because I can't tell you the amount of times you see a quote-unquote contraindication, and you look at that, and at a clinical level, you go, I'm fine with that. Yeah. That's super routine.
Well, I mean, that's the factor of using drugs off-label. Well,
exactly.
Duh.
Exactly.
Aspirin is an off-label drug. I mean, it's not.
Right.
So, I mean, in that case, there's a case in Delaware, I believe, called Amarin or
Amarin. Yeah, the drug. Amarin's for off-label use. Is that the case you're going after?
Amarin sued a generic manufacturer, which is
for Vascepa.
Yes, and the generic manufacturer got off on a motion to dismiss because the judge ruled that their skinny label on it met the requirements. But in the course of discovery over a couple of years, Amarin added HealthNet as a defendant to the lawsuit and said, you're inducing infringement of our patent because you put the generic version of Accepra at a different tier than our drug. And of course, that's what formularies are for, if there's a generic version of the same drug. But in this case, the generic was only authorized for one of the 2 uses of Accepra and not the other one.
Correct.
And the judge basically said, well, he's going to let the inducement case go forward, although he cut the person who was the entity that was alleged to have infringed the patent go.
Right.
And the argument was that you induced the doctor to do something. I said, well, all HealthNet is doing is paying.
Yeah.
At a benefit or another benefit, which comes after somebody has prescribed the drug.
Right.
So how do I induce something that has happened already?
Well, I disagree with that statement. Again, we're well past time, but you just pointed out that in the case of patient assistance programs, that is an inducement, which
Yeah, but
means
you just said doctors don't know how much the drug costs.
exactly, and that's exactly the
So,
question.
so if the doctors don't know what the drug costs, then how are they induced to do anything based on cost?
And that would be the question: when do doctors know what a drug costs? And I think that's the real question.
The long and the short of all of this is that the programs do help. I mean, financially, I mean, obviously, if you're having to pay 400 or 500 or 1,000 or 2,000 or 10,000,
Yeah.
I mean, the drug that was involved in the September case, the
Mhm.
Pfizer
Mhm.
uh, thing, it was a $225,000 a year drug,
Great.
and the Medicare, I think it was Medicare, the Medicare copay for a Medicare beneficiary for a year was like 15 grand.
Great.
I mean, it wasn't cheap,
Great.
and the question is, you know, if the drug manufacturer is going to step in and cover all or part of that $15,000, well, does that help the patient? Of course, it helps the patient. I mean, no question about it. But does that also induce the patient to use a drug that they may not otherwise use? Probably.
But should they be using that drug is the question I'm asking, which is probably the most important question out of all three of these.
Uh, the the anti-kickback statute, the Beneficiary Inducement Act, False Claims Act, all of that stuff, that's
Doesn't
not
answer
a
that question.
question.
I know. I agree. I completely
I
agree with
mean,
you. However, I
the
think
fact that it's a great idea doesn't impact because of the backstage problems that it causes.
yeah. No, I understand why the problem exists, but I think the problem is set up by, and you'll enjoy this because you're a bit of a libertarian, shall we say? Uh,
A
uh,
bit.
but a little bit. But I think the problem exists because people who are not clinicians are making the rules on what's appropriate to prescribe in many cases. And I'm not saying that there aren't health practitioners in insurance companies. I'm saying they're making overall plans for most people, and that may not translate at an individual level necessarily. And as you
Well,
said, the
remember
law,
something that the the idea that CMS is supposed to be following
right?
and the theoretical basis behind health plans is that if you manage the care and you manage the care appropriately such that you streamline it, you don't have a bunch of people not knowing what the other person is doing. If you use medically necessary treatments in medically appropriate locations, that the cost will not only be less expensive, but the outcome will be better. It's the
And the
whole
question is,
concept behind value-based contracting.
yeah, yeah,
So whether you think that's a misnomer, which it could be depending upon how
yeah,
it's done, or whether or not it really means something, that's the idea.
yeah.
So it not only is it cheaper
Mhm.
to treat people that way, it has on a population health basis, not a precision health basis, but a
Sure.
population health basis, it has the impact of better outcomes for most people. Better outcomes for most people also equals cheaper. So theoretically, I say
Yeah,
theoretically, that's the way it's supposed to work.
I
And if
hear
you
you.
start messing with the theoretical part, then the end result doesn't come out the same way. And you know, e-
But
everybody
as you pointed out,
everybody
mhm,
wants precision medicine.
right?
I am
I think
willing to fight to the very last drop of your blood. Um, you know, I I want you and the other 329.9 million people in this country to have the best population health coverage out there. But when it comes to me, I want precision medicine tailored to me and given at me, and I want you to help pay for it.
exactly right. On that
I mean,
note,
that's just human nature. I mean, you can't
yeah,
argue that everybody wants that. I mean,
it reminds me of the whole discussion around artificial intelligence, which is it addresses so many different issues, but may not address any one issue. And that's been the problem when you talk about AI. Everyone says percentage wise it's accurate, yeah, but then you start chasing the percentage because it self reinforces each time. But anyways, that's a whole different discussion.
there are always exceptions to the rule.
Yeah. Well, we're gonna call it because we're so
Okay.
past time. It's not even funny. Kenny,
But
before we
these are
go,
fun.
these are you're always super fun to have on, and you're not afraid to sort of say things as you see them, and I think that's amazing and that's awesome. So thank you. For those people who want to reach you and ask you questions, where can they find you?
At my LinkedIn, they can ask you a question, or they can just email me at kenneth.white@willistowerswatson.com until we get it shortened to wtw.com or something.
Well, until Oprah gives up her URL, if you will.
Yeah, exactly.
I also want to emphasize that there is the 2022 Healthcare Forum and Managed Care Roundtable. You can actually go to this at this bit.ly link. I will also message it out for people who are interested. So I will make sure that goes out. And if anyone has questions, feel free to reach out. Kenny, one more question. What would be your parting words?
Like everybody else, there's got to be a better way. I mean, I think lots and lots and lots of people know what the question is. It's that very few people, if any, have the answer. There has to be a better way. There's got to be a way to help those who need the assistance. I mean, a real quick aside, the PAPs that are the real legitimate ones are supposed to have eligibility requirements. One of those eligibility requirements per CMS is supposed to be income. Now, I don't know if you are on a PAP, but I know that I get benefits on a drug from a PAP, and I have no idea how I would satisfy anybody's income,
Right.
limitations on that. I do make more than the federal poverty level. Thank you, Willis Towers Watson. So, I don't know how, but I mean, I think that's more of a wink and a nod kind of a thing. But there's got to be a way to reduce the cost of the drugs so that the whatever is either the assistance isn't necessary anymore, or that the PAP assistance is built into the actuarial underpinning of CMS and commercial programs. But again, that will require everybody else to pay a little bit more. It doesn't mean that everybody is going to save anything. Very few people will save anything, and those people will save a lot, and everybody else will pay a little. But there's got to be a way to manage it to where some of these medications that, as you have mentioned, are extraordinarily necessary for a few people, that they have the ability to get the medication and to use the medication. And if there's something cheaper that's just as good out there, then they ought to be directed to those drugs. I mean, but I don't have the answer. I mean, I can fix the PAP problem, but that doesn't fix the patient problem.
Which means we've got to get you back and talk about universal healthcare and how much you think it's a good idea.
Yeah, we can talk about that. About a year. Do we have a year to talk about? It'll be a 4-part series.
It's a 4-part series. Perfect. Kenny, this was amazing. We're going to schedule you, obviously, to come back in a few months, but thank you. And
I'll see you in 6 weeks in Nashville.
Yeah. Talk to you soon. Thanks, everyone.
Right. Take care.